My name is Janet Onyenwena, and I'm a Doctor of Nursing Practice candidate at Wagner College. Today I'll be speaking with you about the global burden of congenital syphilis. Syphilis is a sexually transmitted bacterial infection, or STI, caused by the bacterium Treponema pallidum. Syphilis is mostly transmitted through sexual contact, whether vaginal, oral, or anal. The disease starts as a painless sore, typically on the genitals, rectum, or mouth. Syphilis spreads from person to person via skin or mucous membrane contact with these sores. It is not uncommon for people to be infected with syphilis and not even know it. Who is at highest risk? Women, gay, bisexual, and other men who have sex with men. Adolescents and young adults between the ages of 15 and 25, individuals who exchange sex for money and/or drugs, American Indians and African Americans, individuals who frequently engage in unprotected sex, individuals with numerous sexual partners, and those who engage in sexual intercourse with individuals who have contracted syphilis or are Treponema pallidum positive. In 2007, the World Health Organization and partners launched the Global Initiative for the Elimination of Mother-to-Child Transmission of Syphilis. WHO Global Health Sector Strategy on Sexually Transmitted Infections 2016 through 2021 identified as one of its 4 key targets for 2030 the elimination of congenital syphilis as a public health problem, which is defined as less than or equal to 50 cases of congenital syphilis per 100,000 live births in 80% of countries. The following WHO case definition for congenital syphilis applies to both national and global congenital syphilis targets. A stillbirth, live birth, or fetal loss at greater than 20 weeks of gestation or greater than 500 grams birth weight born to a syphilis seropositive mother without adequate syphilis treatment, or a stillbirth, live birth, or child age less than 2 years born to a woman with positive syphilis serology or unknown serostatus and with laboratory and/or radiographic and clinical evidence of syphilis injection, regardless of the timing or adequacy of maternal treatment. Congenital syphilis remains a significant public health problem worldwide despite the availability of preventive strategies for the identification of the at-risk newborn. Congenital syphilis is also the second leading cause of preventable stillbirth globally, preceded only by malaria. According to the World Health Organization 2018 report on the global sexually transmitted infection surveillance, the incidence of congenital syphilis per 100,000 live births decreased from 539 in 2012 to 473 in 2016. Despite this global decrease in its incidence, congenital syphilis remains a significant problem in both developing and developed countries. In 2016, 7 in every 1,000 pregnant women had syphilis. These maternal syphilis cases led to an estimated 143,000 early fetal deaths and stillbirth, 61,000 neonatal deaths, 41,000 preterm or low birth weight births, and 109,000 infants with clinical congenital syphilis worldwide. Congenital syphilis is a disease that occurs when a mother with syphilis passes the infection onto her baby during pregnancy. This could lead to miscarriage, stillbirth, prematurity, low birth weight, or neonatal death. Babies born to women with untreated syphilis may be stillborn or die from the infection as a newborn. The CDC recommends screening all pregnant people for syphilis during their first prenatal visit. Congenital syphilis is a nationally reportable disease across all 50 states. It is required that all positive cases be reported to a local public health agency. High-risk individuals should be tested at their initial visit, early third trimester, and at delivery. As of 2023, here is the most recent data of global reported cases of congenital syphilis. Clinical manifestations. Rhinitis is one of the first clinical presentation, usually in the first week of life. Rash. Maculopapular rash usually appears 1 to 2 weeks after rhinitis. Hepatomegaly. This is the most common finding and may occur with splenomegaly. Cortical demineralization of metaphysis and diaphysis areas of long bone. Jaundice, that is yellowing of the skin or eyes, and generalized lymphadenopathy. So standard and contact isolation is needed. Here are some examples of clinical manifestations in infants presented on the previous slide. Transmission of syphilis. Syphilis can be transmitted transplacentally to fetus following maternal spirochetemia or intrapartum by contact with maternal genital lesions. Early congenital syphilis is when clinical manifestations occur below 2 years of age. Late congenital syphilis is when symptoms appear after the 2nd year of life. Timely identification of treatment of women early in the pregnancy will decrease significantly the sequelae of congenital syphilis. Delayed diagnosis and treatment can lead to late persistent clinical features of Hutchinson's triad, skin gummas, scarring, facial changes including frontal bossing, saddle nose, prominent maxilla, and skeletal abnormalities. Initiation of treatment in some infants can lead to a Jarisch-Heischmer's reaction leading to fevers, chills, hypotension, and possibly fetal death as a result of an inflammatory response to the dying spirochetes. Laboratory and radiographic testing to aid in diagnosis are presented on the next slide. Histologic examination of the placenta and cord for the typical pathological changes and presence of spirochetes. Dark field microscopic examination of nasal discharge if present. Long bone radiographs that may show finding of pathologic fractures, metaphyseal serration, localized demineralization, and osseous disruptions. Chest X-ray which may show diffuse opacification of both lung fields, non-troponemal tests, specific troponemal tests, cerebrospinal fluid abnormalities, and polymerase chain reaction tests, PCRs, for detection of troponemal DNA. Treatment for congenital syphilis when the disease is confirmed or likely to be present is infants up to 4 weeks of age, aqueous crystalline penicillin G, 50,000 units per kilogram per dose intravenously every 12 hours in the first 7 days of life. After 7 days of life, 50,000 units per kilogram per dose intravenously every 8 hours for 10 to 14 days. Alternatively, procaine penicillin G, 50,000 units per kilogram per day intramuscularly for 10 to 14 days. Infants older than 4 weeks and older children, aqueous penicillin G, 50,000 units per kilogram per dose every 6 hours intravenously for 10 to 14 days. Prognosis. The prognosis is excellent if diagnosed and treated appropriately in a timely fashion. Syphilis is easily treated with penicillin. Increased risk for worse outcomes and possible death in premature infants, those who have a delay or do not receive proper treatment, patients who display an extensive spread of the disease with multiple organ failures, and infants with a severe Jarisch-Hersheimer reaction upon treatment. The treatment of congenital syphilis involves a team approach, including infectious disease specialists, neonatology, pediatrics, obstetrics, and the nursing staff. Infectious disease specialists, pediatrics, and neonatologists are usually involved in the acute treatment of the disease. Pediatricians follow up on successful eradication of the disease and monitoring for disease complications, and obstetricians test pregnant people for syphilis and treat syphilis in pregnancy, which significantly decreases the incidence of CS. Screening recommendation for providers. Pregnant people are at risk of getting syphilis before or during pregnancy. Providers should screen all pregnant people at their first prenatal visit and early within their third trimester. Providers should screen many pregnant people at delivery, especially people without a documented syphilis test from earlier in the third trimester, people with no or inconsistent prenatal care, people with a sexually transmitted disease diagnosis during the past year, people with current injection or non-injection drug use, people who have been incarcerated during the past year, people currently experiencing homelessness or unstable housing, people with multiple sexual partners, people who have a sexual partner with any of the risk factors stated above. Even without the listed risk factors, providers can decide to screen for syphilis at delivery. Plan to address the issue of congenital syphilis. Investing in screening and treatment for syphilis in pregnant women ranks as one of the most cost-effective antenatal intervention. Monitoring and scaling up the screening and treatment for pregnant women remains paramount to measuring progress towards the elimination goal. Measuring how many adults and infants are affected by syphilis with regional and national level estimation is crucial to guide the capacity of health systems to strengthen the prevention, detection, and treatment of syphilis. Increase funding for outreach and educational programs. Reopening testing centers in communities worldwide. Accessibility to healthcare, and avoid stigmatizing those diagnosed with congenital syphilis. Stigma makes it harder to end the outbreak and can stop people from accessing services. Conclusion. The number of adults and children affected by syphilis remains unacceptably high. It is crucial that all women are provided with early syphilis screening and treatment as part of high-quality antenatal care to enable a positive pregnancy experience. In addition, health systems and programs need to ensure that all people diagnosed with syphilis, as well as their infants, are effectively treated, and that their sexual partners are reached for testing and treatment. Countries can also work to reduce syphilis prevalence across populations by ensuring that testing, treatment, and partner referral for the infection are implemented beyond antenatal care. Here are links for more information on congenital syphilis. This concludes my presentation on congenital syphilis. Thank you so much for listening to the end. I hope you found the information informative, and I could be reached at this email for questions or comment. Thanks again, and take care.